to say thanks again for coming and enjoy your lunch and enjoy the program. Peggy Neville is going to introduce our keynote speaker today. Peggy, come on up. Teach some Baptist.
Hi, everybody. Thank you for coming. My name is Peggy Neville. I'm the breast care coordinator at Baptist downtown at the Hill Breast Center. I am here to introduce Dr. Desai. Dr. Desai was born and raised in Jacksonville and graduated from the Bowles School. Dr. Desai received his medical degree from the University of Florida, where he served as class president for all 4 years. He completed his plastic surgery residency in St. Louis University. Dr. Desai also completed specialized cosmetic surgery training at the University of Alabama at Birmingham, under the direction of internationally renowned plastic surgeon Dr. Louis Vasconez. While at the University of Alabama, Dr. Desai served as a clinical instructor. Dr. Desai is board certified in plastic surgery. His interests include cosmetic and reconstructive breast surgery, anesthetic and endoscopic facial and eyelid rejuvenation, minimally invasive surgery, and body contouring. It is my pleasure to welcome not only a talented surgeon, but in my opinion, a darn nice guy, Dr. Ankit Desai.
She said she was going to read that. Peggy's known me, I don't know, about 25 years, so she could have said a lot more, and she got the scripted version down. So it's a pleasure to be here today. Can everyone hear me really quick, just with the microphone where it is? Great. Obviously, as a plastic surgeon, a large focus of my particular practice is the reconstruction of the breast when it comes to regards to women afflicted with the terrible disease of breast cancer. And I've been fortunate to work with breast care coordinators like Peggy and helping so many women at least learn or educate themselves about what their options are. I think so often the entire story is you get the diagnosis of breast cancer. The focus is all on kind of this whirlwind of, well, what do I need to do to get it out, and then what kind of chemotherapy do I need, and how much radiation I need, and then you get through the whirlwind and you never really maybe took 5 minutes or a weekend or to pause and say, well, what are the elements? What happens after all that's done? And that's really where plastic surgery plays a role, is improving not the quality of life. Because survival has gotten so much better. So many more women with breast cancer are living, and that's a testament to the medical oncologists, the general surgeons, the radiation oncologists. But really then, what kind of quality of life do we have, or what are we providing these women with as they go forward? And that's where I hope to be a benefit to women, of all walks of life, from all ages, reconstructed or helped women as young as 22 to as old as 74. It's not for everybody. Some that it's not important to them, and some it's very important. And when it's important, whether it's right after or years later, is so variable. But really, the message here is to educate you on what some of the options are, because if I was to educate on all the options, we'd be here a lot longer. But what are some of the options? What are the newest kind of things that we're doing to try to improve outcomes for women, with breast cancer? And that way, maybe you can take home that message, because so many women know somebody with breast cancer. I mean, just show of hands, how many women, at least know someone that's been with breast cancer? Yeah, pretty much everyone in this room. So, knowing women and people in general, basically, a lot of it, you ask your friends for advice. And so, what did they go through, or what did I go through, or do you know what these things are? Interestingly enough, I think because of the whirlwind that's sometimes associated with breast cancer, women are not necessarily told about their options for reconstruction at the very beginning, and that's something that we need to do a better job of. I think we definitely, with the multidisciplinary breast team at Baptist, are able to provide women with, if they so choose, that they have the option, if they want to meet with a plastic surgeon, whoever that may be, that they presented that. There's actually a state law in New York now that's been passed mandating that women be told that they have an option for breast cancer reconstruction. And that's just to highlight that, not everyone is being told. So kind of get into it, breast cancer, and anyone who has questions, feel free to just interrupt me at any time. You don't have to wait till the end. There's a lot of pictures, so there won't be a lot of as much text, all right, as you may be used to. But breast cancer, obviously the most common malignancy in women. It's 1/3 of all cancers. Second leading cause of death in women, and there's about 250,000 new cases every year. When I see a patient, and most of what I'm talking about today is going to be what kind of reconstruction we can offer after mastectomy. There's a whole host of options, and it kind of gets a little bit more complicated and is suited to that particular patient when you talk about reconstruction after lumpectomy. But there are, just to kind of highlight, if you've had a lumpectomy, know someone that's had lumpectomy with radiation treatment, and they are not happy with the asymmetry that's been created or the way it looks, sometimes there may not be options, but more often than not, there are certain options those women have to potentially help solve those discrepancies, like breast size or breast asymmetry. That's not going to be the focus of this talk. We're going to concentrate on post-mastectomy reconstruction because it is a little bit more common. And so when I see a woman that, either by choice, and a lot of women are opting for bilateral mastectomy, some of it's because of fear, some of it, MRI, technology is picking up cancer that they didn't necessarily see on mammograms. So when I see a patient either electing to have a mastectomy because that's just simply what they want, or that because of the size of the tumor or the nature of the cancer that need a mastectomy, I generally say, well, breast reconstruction is a process. It really is. And so the process can begin at the time of mastectomy, or it can begin any time after you're done with your treatment if you so choose. Most of the patients that opt into delayed reconstruction are either by their own choice, meaning they've gone through chemo, radiation, if they needed either one of those, and they've come back for reconstruction at a separate time. So they do it by their own choice, or they're kind of pushed into it because for the need of radiation treatment, and the results are going to be better if you wait till after. So we talk about the process, and there's generally 4 things we need to reconstruct. There's a skin envelope, so there's more. If you look at the breast from the side, there's more skin on the bottom of the breast than there is on the top. There's the gland itself, the tissue that's underneath the breast, under the skin, that's actually the part that's removed for the most part. There's the nipple, which is the projecting portion, and then the center part of our breast, and then there's the areola, which is the pigmented portion. And we can reconstruct 1, 2, definitely 1 and 2 are part of the reconstruction of the breast, the skin envelope and the gland. And some women opt for nipple areola reconstruction, some don't. And so it's tailored to what the patient desires and what's important to them. But in general, those are the 4 major elements of what we, as plastic surgeons, say this is what we're trying to restore as whole. And if we talk about immediate reconstruction, that means that we're in there with the general surgeons at the time of the mastectomy, starting the reconstructive process. And what are the advantages? The aesthetic outcomes are better, so the cosmesis is better. There's less patchwork, smaller scars. There's less psychological trauma. And many of these women with now skin-sparing mastectomies, and we're preserving the skin envelope, they wake up either with a whole breast, depending on the technique we use, or with the start of a breast. May not be as big as they were, but they're not flat-chested, and so that eases their fears or what they thought. I just operated on a surgeon's wife, and she, until we met 3 or 4 times. Her husband's a surgeon. He talked to her about it, and until the surgery was all over, then I walked in the next morning. She's like, well, this is great. This is not as bad. The mind lets you think that things are going to be much worse, that they're going to look much worse. After trying to explain the technique, she thought that the breast was really literally just chopped off, and there was like a hole there. And so what we imagine is often a lot less severe, or it's a lot worse than what the reality is. And so you're going to see pictures, and generally we try to minimize the scarring as much as possible for these mastectomy women as we try to reconstruct them, so that when they look in the mirror, they don't see necessarily the scar from breast cancer. They see their breast, they see a sense of wholeness. And we're getting better and better at minimizing those scars, and it depends on the patient's particular anatomy. But that's one major advantage of immediate reconstruction. The scars are smaller. You're able to preserve some certain anatomical structures, and really that does add to the cosmesis of the overall result. The disadvantages are, you know, if you're having radiation treatment, you can sometimes have immediate reconstruction. For the most part, you're probably better off having delayed reconstruction for cosmetic reasons. This is just an example, and I don't know how well you can see it, but this patient had an immediate right breast reconstruction, and this patient had a delayed right breast reconstruction. And you can see there's a scar here and here all the way around. And this is where Jerry Millard within the Pink, I met with her yesterday. We were talking about why there's a big, larger scar pattern. And because of the delayed reconstruction that was radiated, she needed more of that skin envelope because it was flat when we started, and so we needed to use that skin to recreate that skin envelope. And on the left side here, you can see, you know, the scar pattern is much smaller. It's mostly hidden with the areolar reconstruction, so that, you know, you can really have improved outcomes. You know, I hear a lot from the medical oncologist, you know, that or maybe a little bit, you know, with gray hair and aging in their tenure, but that immediate reconstruction is bad, and it delays chemotherapy, and so when we look at it, you look at every major study, it says that it does not delay chemotherapy, that immediate reconstruction has a significant psychological impact on the women. 95% who had immediate reconstruction were glad that they had it. 3/4 of women that had delayed reconstruction wished they had immediate reconstruction. It adds to body image, self-esteem, and when you look at the data as far as safety, women that have immediate reconstruction, and we're talking a study on 17,000+ patients, they lived just as long, they had no delay in chemotherapy, and they had no difference in local recurrence rates. So they're living just as long as those women that didn't have immediate reconstruction and hasn't delayed chemotherapy. So a lot of that, you know, is kind of just old thinking, and trying to change that since I've moved here. Skin-sparing mastectomy is where the nipple areolar complex is generally removed, and that's been the standard of care in the 90s and the early 2000s.